Hello everyone, I am Dr. Yidersal, a consultant anesthesiologist, critical care and pain medicine specialist. For today, we will see about the basics of mechanical ventilation. So, as you know, spontaneous breathing or the breathing system that we have is negative pressure ventilation, and the opposite is true when the patient or some patient is on mechanical ventilator. They will put on positive pressure ventilation. So before that, we will see about the basic anatomy of airway, the upper airway and the lower airway. So upper airway is used for humidifying inhaled gas, and so it's also a site for most resistance to airflow, whereas the lower airway is the conduct. There are two types of airway: anatomical airway and physiological. So they are conducting airways and also airways that act for gas exchange. So as you know, in anatomy of respiratory system, up to the from the trachea up to the primary bronchi, secondary bronchi up to the 16 branches of bronchioles is anatomical airway. They will use for conducting airway or for passing the air. So after that, from the 17th segment of bronchioles to the alveoli, they will use as a gas exchange. Uh, in naturally, we have, as I said, negative pressure ventilation, negative pressure circuit, and it has a gradient between the mouth and the pleural space that can cause a driving pressure, and this needs to overcome resistance and maintain alveolus open and overcome elastic recoil forces. When it comes to concept of mechanical ventilation, they use a positive pressure at a certain rate and certain set points, and the amount of gas delivered can be limited by time, pressure, or volume, and the duration can be cycled by time, pressure, and flow. And when it comes to the indications for mechanical ventilation, one is, for patients who have type 1 respiratory failure or who have oxygenation problem. So this mechanical ventilator will help for giving that and also for work of breathing. And the other thing is for protection, and the other thing is for type 2 respiratory failure. And in critically ill patients, this type 1 respiratory failure can arise to up to 30%, and it's very important. There are different patients like cardiogenic pulmonary edema, septic shock or sepsis with ARDS, or different causes of ARDS, so like pneumonia and the like. So these are type 1 respiratory failure. If patients have like COPD, asthma, or restrictive type of problems or anatomical problems that can cause, type 2 respiratory failure in these patients, or we may also intubate these patients. The other thing is for neurocritical patients who have an ability to protect the airway because of, depressed or absence of the reflexes like cough and gag reflex. As I said, these are the split indications, or each by each. Inadequate oxygenation, no supply, not corrected by non-invasive one like up to face mask with the reservoir. The other thing is inadequate ventilation because of increased carbon dioxide, partial pressure of CO2. The other thing is retention of pulmonary secretions like for bronchial toileting in different causes like neuro or different neuromuscular problems. The others are airway protection, as I said, from because of reflexes depressed or absent. The others are because of to decrease work of breathing or eliminate work of breathing, and reduce oxygen consumption like in cardiac patients, in neurologic patients, and the like. And the other thing is neurologic dysfunction, like when the GCS is less than 8, when the patient has frequent apnea, and the central problems like problems in bones and medulla, that which are actually the sites for for respiratory and cardiac center, and that's are for protecting the airway. When you see the principles of mechanical ventilation, as uses positive pressure ventilation involves delivering of mechanically generated breeze to get oxygen in and carbon dioxide out. Gas is pumped in during respiration and a patient passively expires during expiration. So inspiration is active whereas expiration is passive. You should know this. The sum of inspiration and expiratory time is the respiratory cycle or breeze. When you see the basic settings of a ventilator, we see the tidal volume, the respiratory rate, the pressure, and the FiO2 and the peak in the expiratory pressure. The tidal volume, it can be volume control or it can be pressure control. In pressure control, we use like from 10 up to 20 centimeter of water to generate for some amount of volume of tidal volume calculated for the age. And the other is volume control. We use it the calculator like we use usually like six to eight and 18 breaths per minute based on the patient disease condition. PEEP also can be said used can start from 5 centimeters of water up to you can extend up to based on the compliance of the lung up to 20. The other is FiO2. We can start from the 0. Uh, so one is uh, this is observation like that we call it mode. One is mode you will put or pressure control or volume control mode in controlled mode ventilation in support assist ventilation also like that to like 50% oxygen or whatever you like based on the patient condition. The other is respiratory rate and respiratory action set tidal volume at and limit and cycling. When you say a trigger, based on the setup that you put, it can be patient trigger or that can be ventilated. So when the patient has some flow, or when the flow of breathing is reaches to some point, the set point, then the mechanical ventilator will give breath. And so setting can be pressure limited or volume limited. And volume limited, you will put, or you will put the tidal volume constant, and the pressure will be vary. And the other sets are like FiO2, respiratory rate, IA ratio, or I time. And peak in expiratory pressures are common for pressure and volume control the expiratory pressure, or peak airway pressure. So you'll put these pressures and you will get different volume of tidal volume. So for example, if you put respiratory 12 for some patients, then for 1 minute, if the patient is taking 12 breaths, then each breath will have 5 minutes, so 5 seconds. So you can calculate based on inspiratory expiratory ratio. Usually the usual or the normal one is 1 to 2 ratio, but based on the hypoxia or hypercapnia condition of the patient, you can increase the inspiratory in time, and or increase the expiratory time respectively. The others are FiO2 can be put on 100, and you will win the patient downward based every 20 minutes based on the patient response. The other is peak in expiratory pressure. You can start from some patients like in pediatrics or neurocritical patients. You can start from 3, or you can start condition. For example, if the FiO2 requirement is 70, you can't put PIP like 5 or 4, because the requirement is high. You should also increase the PIP to like 7, 8, up to 10, 12, because the one that can increase oxygenation is peak in expiratory pressure in the FiO2 pose. So the one that can increase the ventilation is the respiratory rate and tidal volume, or pressure that can generate the tidal volume, the safety pressure. So control every breath. It can be assisted, or sometimes it can be synchronized intermittent mandatory ventilation. Another most important thing is in how like PIP is peak respiratory pressure. It is the summation of like plateau pressure plus mean airway pressure. So plateau pressure also can be calculated with or uh, the pressure that can generate tidal volume is plateau pressure minus peak. So you can calculate and you can get that. So the other thing is mean airway pressure. The other is CPAP, continuous positive airway pressure, that we use in support ventilation. The other is IA respiratory time, or IA ratio. The other is tidal volume, amount of gas delivered each breath. And others are most important thing. Other most important thing is principle of mechanical ventilation. Mechanically ventilated patient usually receive positive pressure, positive in the expiratory pressure, to overcome the loss of physiological PEEP provided by the larynx and vocal cord. PEEP is delivered throughout the respiratory cycle and is synonymous to CPAP, but in the intubated patient, uh, 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 standard PEEP setting is like starts from 5 in adult, as I said before. Sedation often required to prevent ventilator patient asynchrony, even up to the level of muscle relaxant. Uh, why this peak airway pressure is important? Because to decrease the ventilator-induced lung injury. We usually put a PAP, or peak airway pressure, less than 35, because mechanical ventilator is injurious to the lung. The other most important topic is troubleshooting. So troubleshooting is when the patient is hypoxic or hypercapnic or asynchronic or something, happen, bad thing happen in patients, you should have troubleshooting. One thing is it working? Is the mechanical ventilator working? So you should disconnect the patient from the mechanical ventilator and back the patient and auscultate bilaterally and see that the problem is in the airway or the patient or a mechanical ventilator. The other thing you should assess the ABG, intidal CO2, pulse oxy, all these things will you may have like chest X-ray or lung ultrasound. Recently, we usually use, for example, in my setup, we didn't send the patient for chest X-ray for troubleshooting. We will assess using ultrasound. So the other thing is look the ventilator or peak respiratory pressure or expired tidal volume and the like, and alarming systems and the like. So if the like expiratory tidal volume is very low, like the patient's airway may be like detached or maybe like wrongly intubated or partially intubated in one lung, or it can be filled with secretions. And ensure 100% oxygen. And the other thing is eliminate the ventilator circuit as a source of a problem. So this is the most important thing. The other thing is bag by hand can also help you gauge the patient's lung compliance. So when you bag the patient, you will know that the resistance is high or not. So that if the patient has like bilateral air entry, but if there is some secretions, you will know that based on that, and it will suction the lung. The others are airways always first. So as a tube in, this is the most important you should know. So in this case, internal carbon dioxide can also give you a clue to confirm that ET2 is in situ or not. The other thing is this CO2 will not guarantee whether the ET tube is in one lung or in trachea. So the other thing is you should auscultate for bilateral equal breath sounds, and also you will see change in exams. So you may get like atelectasis or bronchospasm or pneumothorax, pneumonia. Consider needle thoracentesis when there is like pneumothorax, and you can also rapidly assess using the lung ultrasound. Okay, focus. So the other thing you should also assess the safety condition of the patient, whether the patient develops shock or not, or in different things you should also assess whether there is shock or not. The other thing is, well, is this is that working? So then the patient is does the ventilator need to do more work? Patient unable to do so, underlying process worsening or new problem, or for example, if the patient ARDS, if the underlying process is worsening, if there is any air leak, does the patient need to be more sedated? If there is air leak, like for example, if the like 82 like balloon is like not inflated, you can inflate and see. And the other thing is you can also exchange the 82 based on the tube exchanger or Fuji. So the other thing is, if does the patient need to be extubated? You should also think that, because some patients may be intubated for temporary use, and that time the patient can also be ready for extubation. That especially in pediatric patients. The other is ventilator is only is it working or not? Should also see. So the other most important thing is most of mechanical ventilator, all ventilator do only one thing, okay, push in air in inspiration on compressor, and it has two valves like inspiratory and expiratory valve. Okay, when the during inspiration, the inspiratory valve is open, expiratory valve is closed. The patient inspires and inspiratory pause, both valves closed, because the expiratory valve was closed, and when there is inspiratory pause, the inspiratory valve will also be closed, and help us to know the plateau pressure, in especially in volume control ventilation. The other thing is expiration, inspiratory valve is closed and expiratory valve is open, and This peep-way expiratory pause also can help pause valves close and can help to keep some air in the lung because this is PEEP. These are, volume control and pressure control. The modes, volume control tidal volume is always constant, and pressure control tidal volume is vary. Pressure control inspiratory pressure is constant, whereas tidal volume is vary. And the other thing is inspiratory time can be said in both things. And inspiratory flow is important in volume control, and also you should set this inspiratory flow. And in pressure control, it is variable in accelerating type, and inspiratory flow waveform is decelerating, as I said, and this is somewhat physiologic, comparable with physiologic, and inspiratory flow is constant in volume control. So the other thing is set parameter is and as I said, in volume control is the only thing that we said is airway pressure. I mean, sorry, the tidal volume. Okay, and the other common purpose. So patient ventilator asynchrony due to fixed flow rate, but due to the decelerating type of flow rate, it is comparable with the patient physiologic condition. So pressure control ventilation has less, asynchrony. So in pressure there is a leak compensation, in volume there is no leak compensation. But in volume, in a set parameter is tidal volume, airway pressure is variable, and constant tidal volume in the face of changing lung characteristics. In pressure, the set parameter is airway pressure, and the tidal volume is vary, and with changing lung compliance of the condition generally. Okay, so what to monitor is, one thing is peak airway pressure, the other thing is plateau pressure, and the other thing is pressure alarms, and also different like low oxygen alarm and the like. During pressure control, you should also see the expired tidal volume and expired minute ventilation. Okay, so the other thing, most important things are trigger, limit, and cycling. So trigger can be time trigger or pressure trigger or flow trigger. Okay. So trigger, time trigger is ventilator breathes in constant, respiratory rate frequency, and it's independent of the patient effort because it's scheduled within the time. So and this is works in patients who are on neuromuscular reactions, in patients who are in comatose and the like, who are not allowed or who are not in spontaneous, no spontaneous breathing. The other thing is pressure trigger. You can also patient breathing produces a decrease in baseline circuit pressure, which starts in inspiration. So the negative inspiratory pressure, that means -3 or -2 or -1 centimeter of water, can help the patient to sense the mechanical ventilator to start breathing. So because this is pressure trigger. The other thing is flow trigger. Ventilator senses inspiratory flow by the patient and initiates inspiration. Okay. So as I said, this is one cycle of breathing. So this is a patient trigger. This is a machine trigger. There is no negative, inflection. So this is a machine trigger. This is a negative inflection. So this is patient trigger. So the other most important thing is limit. Okay, it limit can be pressure limit, flow limit, or rate limit. Okay. So inspiration continues up to the limit of the duration of inspiration, and it remains as the level till changeover to the expiration occurs. Okay, so the other most important, when you see the limit, like for example, in controlled ventilation, it can be like pressure control or volume control ventilation. So when there is like when there is like pressure control ventilation, so this time the trigger can be pressure, and also in control, sorry, in assisted control. Most of the mechanical ventilators are assisted control actually. So if the patient is not allowed to inspire by himself, so the trigger, the limit, everything can be, constant, and okay, it's based on the expiratory rate and the like. Okay, but and also the um, the trigger can be time trigger, and limit can be rate limit, like based on the respiratory rate, and cycling can be based on that, based on I ratio. Okay, but during assisted control, the patient has like some assistant, okay, assist the mechanical ventilator. The inspiratory trigger can be based on the pressure, and the volume control, it's different. Based on the pressure, it can be like pressure trigger, based on the volume assisted control, it can be like flow trigger. Okay, that means to some amount of inspiratory flow, the ventilator senses and the ventilator keeps like breathing. Okay, the other thing is limit. Okay, in limit, like in assisted control, like in pressure, like there is a pressure limit. Okay, in volume control, assisted control, the limit can be flow limit. Okay, so inspiration continues up to the limit of the duration of inspiration, and it remains at the level till changeover to the expiration occurs. The other is most of the time is cycling. Okay, this is a change from inspiration to expiration. Inspiration ends when some variable has reached a preset value. This can be time cycling, or flow cycling, or pressure cycling. As I said, time, fixed rate or time, these are for control. Okay, most ventilator measures flow rather than volume. So in volume control, we use like flow cycling when the expiration flow reaches a preset value pressure, like in pressure support. So the other time is most ventilator measures flow rate rather than volume with a set flow rate. Okay, adjust inspiratory time, hence time can be cycled. Okay, so this is in in volume control, like based on set flow rate. Okay, like for example, we can say like cycling can be started after 75% of the inspiratory flow is reached, so the expiration starts. So in in pressure control, so after say some set of inspiratory pressure then reached, then the because lung is like balloon, so you inflate initially the lung pressure is the balloon pressure is small. Then when the air is in, then after some time the pressure will be increase up to reach to the some stated inspiratory pressure. So that time there will be cycling. The other thing is flow cycling. Okay, when it reaches some rigid flow like 75% in the leg, then the cycling will be started. Other is, as I said, time cycling, because of in some patients who are not allowed to have spontaneous expiration. Normal expiration, as I said, is it is passive. It starts from start of expiratory flow to beginning of inspiratory flow. So most commonly baseline pressure is controlled PEEP or CPAP. So there are different type of breathing. Okay, one is mandatory breath, the other is assisted breath. Okay, if the patient has trigger, if the patient is not allowed to breathe, so it's mandatory breath. The other thing is spontaneous. We can define or classify into mandatory or spontaneous. Mandatory can say that intermittent mandatory, or it can be assisted breath. Okay, the spontaneous breathing, the patient starts and ends inspiration based on is controlled by the patient or determined the patient, and the mechanical ventilator only supports the some pressure to reach the baseline and to get some amount of tidal volume. So controls are the breath pressure control, can be volume control, and it can be mandatory or spontaneous or a combination. It can be a conditional, any variable which may determine a change in ventilator function. So in volume and the pressure, as we said already, as it has been said, so pressure can be controlled in pressure control, and inspiratory pressure or air pressure. The other thing is volume can be controlled in volume control ventilation. So trigger can be time trigger or pressure trigger or flow trigger. Okay. The other thing is limit can be rate limit or pressure limit or flow limit. The other thing is cycling. It can be time cycling or pressure cycling and the like, okay, or flow cycling. Other, set parameters are FiO2, air ratio, respiratory rate, PEEP, and the like. These things are common for all. Each additional assisted breathe at a prefixed tidal volume or pressure. So assisted control can be, there is a prefixed tidal volume or pressure, but the trigger can be the ventilator or the patient. When the patient can't, the ventilator will give you a breathe based on the set respiratory rate. But when the patient can, the ventilator adjusts that and senses the patient's trigger, and it gives breathing based on the set assist control of ventilation. Can be volume or pressure control. Limit can be flow or volume cycle, or volume limit or pressure limit, and this obtain has been said. Synchronized intermittent mandatory ventilation. It is mandatory, but is synchronized with the spontaneous breathing with the patient. Ventilator creates a time window around the scheduled delivery of mandatory breaths. If a patient effort is detected, then it will give synchronized breathing with the patient inspiration. If no patient effort is detected, it delivers a breath at scheduled time. This is SIMB. This is usually currently in my setup we use for pediatric patient only. We didn't use even for weaning. Intermittent mandatory ventilation can be, machine is triggered breezes and with the spontaneous breeze allowed in between, so there will be a chance of asynchrony. That's why the SIMAB was invented to avoid this asynchrony. But it has even more fatigue, more increased metabolic rate, and it will cause harm for the patients. So this is the research suggests. So the other is support base, pressure support. Usually we use like pressure or support base. It can be inspiratory or it can be expiratory support. Okay, CPAP is continuous positive airway pressure. We can give like PEEP and for the patient, so that after some amount of pressure the expiration will stop and the inspiratory comes. But if you give like inspiratory support as well, we call this is like uh, uh, pressure BiPAP, okay, both inspiratory and expiratory supportive ventilation. So this supportive ventilation is all the thing, like the trigger is the patient, the limit is the pressure. So there is some limit of pressure to avoid lung injury. We use the limit. The other thing is the cycling, it's flow cycling. So PSCV or pressure supportive ventilation is a spontaneous mode, and the patient initiates breath and the ventilator delivers a preset inspiratory pressure to help overcome airway resistance, and because there are a lot of resistances including the endotracheal tube and different things. So patient controls the rate, the tidal volume, and the ventilation. So tidal volume is variable and can be used in conjunction with the CMAB or CPAP. Always set low tidal volume, minute ventilation alarm, and apnea backup. So that when the patient is apneic in support ventilation, then the backup apnea ventilation will start and will give the set controlled ventilation. So in this case, we will set the pressure support, PS pressure support. We can start from 6 to like 10, 12, and the other is PEEP, FiO2, and apnea setting. These are the things which should be done in pressure support ventilation. The other is three golden rules. So never silence the alarms unless the problem is identified, sorted out, and also chest is clearly moving, patient is put on ambu bag. So when in depth, ambu the patient and see the airway resistance, and also fall in SpO2 and see the saturation in the leg, and and also auscultate the patient and see the troubleshoot the problem and identify and solve. So ventilator strategies in ARDS we will learn in other time, and thank you for now.